a reminder for myself to stop in time. So my name is Paul Galvin. I'm head of ICT for Health Strategic Programs in Tyndall. But what I want to talk here is to give some, I suppose, an exemplar of a roadmap to precision medicine. And we've heard about the multi-ket approach from the previous speakers and how we can move that into smart digital medtech, and how that, I suppose, part of the philosophy that we have is how to deliver impact from the excellent science, and also how do we combine what I call the ABC ecosystem, which is combining the academic, the business, and the clinical successfully. So I'll give you some examples, or one scenario in particular that illustrates this. So it's not about the technology for all of it. For us here in ETPN, in many cases, we're pushing the technology. It's not even about the healthcare professionals or the healthcare industry. What it's really about is precision medicine is about the patient and their futures, and I think we have to keep that as our focus. So since this session started about 30 minutes ago, 2 people will have died in road accidents. 2 people will have been, and this is US statistics, 2 people would have been shot dead. 2 women will have died of breast cancer. 1 person will have died of AIDS. But probably what's surprising to many people is that 11 people will have died of medical errors. It's the 3rd biggest cause of mortality. So what can we do about this? Essentially, all medical devices are training tools. So the old mantra for a clinician of see one, do one, teach one is no longer sufficient, especially when the medical devices are multi-ket systems. It's the old days you could pick up a phone and use it. Now you almost need the instructions of how to use some phones or IT systems. So we have to look at the medical procedure pathway, which includes the patient, the procedure, the device, and the practitioner. And so we have to ask about, in terms of the procedure, what's the procedure for? What is the procedure? Is it who are the experts and so on? I'll skip through this a bit quicker because we're back on time. We also have to look at the device. What will the device be used for? What information does the person who's using it require? If we look at the practitioner, we think in terms of, sometimes the word competence is mentioned, or is the person competent to do the job? If we look at the scale from amateur to expert, we have amateur, competent, proficient, and expert. So we're looking for our clinicians to be proficient. And how do we measure this proficiency? And I'll come to that in a moment. And how can it be acquired? We work very closely with a new research centre that's been created in University College Cork. It's known as the ASSERT Centre, which stands for Application of Science to Simulation, Education and Research for Training. And so it's looking at how you can train and define the proficiency of a clinician for a particular device. So you look at a new device, a new procedure. You have to characterize that procedure. You might have 1,000 different microtasks. You then need to identify which are the critical microtasks that are critical for the outcome. There might be 5 or 10 of those 1,000 microtasks that define whether there's a good outcome or not. You need to define metrics that measure whether those microtasks are performed well or not. Those metrics need to be validated by experts. You need to be able to quantitatively define proficiency standards, and then have a deliberate practice of simulation training. So imagine here if you were to be interviewed as you left in the afternoon, and somebody said, what did you learn today? That would be, you could give an answer and you'd be happy to go home. But if you had to reach a certain standard before you were allowed to go home or go to the event this evening, you would have been probably paying a bit more attention and working a bit harder during the day to understand everything. And that's essentially what deliberate practice proficiency is it's ensuring that somebody doesn't perform a procedure unless their proficiency has been validated. So then you have what's known as proficiency-based progression and clinical practice. So how do we measure this? It's typically measured by a clinician, an expert clinician looking over the shoulder of a trainee, either in a high-fidelity simulation suite, in a multifunctional simulation suite, or as things progress in a real clinical scenario. In the emerging area of virtual reality simulators, and here we have an example of an endovascular virtual reality simulators made by Mentis in Sweden. And so what you can do is you can very precisely measure the performance of an individual doing a particular procedure, including measuring how much fluoroscopy is used for an endovascular procedure and so on. And you can very quantifiably measure this. So we're moving then from measuring using a virtual reality simulator. We now want to move back in terms of the technology to augmented reality for enabling the device to measure multiple parameters. We'd like to think that we're moving towards precision medicine, and in many cases the technology is still precision engineering and quite blunt. When we think of augmented reality, this is a paper from Otto et al. In 2013, just showing a very simple label where using an existing doxycycline treatment is able to highlight necrosis in teeth. But many of you have already described nano-diagnostic agents that can be used to identify specific tissues to enable that augmented reality. And so we have the biophotonics area is emerging with multiple different approaches for enabling augmented reality. It's preferable if we can use label-free detection, and I'll give you some examples of that in a moment. One of the projects that we were involved in was working with a guidewire company called Lake Region Medical on photonic nanosensors. So they wanted to measure the blood flow using a guidewire, and essentially, without going into too much detail on the technology, was putting a nanosensor at the tip of the guidewire. Guidewire is about 1/3 of a millimeter in diameter, and so being able to use a Doppler flow measurement at the tip of the guidewire to measure the blood flow as it was being used to deploy stents. So the challenge here was not only to put the sensor at the tip of the guidewire, but how to make the guidewire in a way that it could connect like a USB port with the instrument in the theater, and being able to manufacture enough of those, I think there was about 20 of them manufactured, to do some clinical testing. So this is an example of how we can enable augmented reality in a minimally invasive surgical device as small as a guidewire. We can also put very sophisticated electronics. This is a device we made several years ago, a smart pill, but we can now put all of the integrated sensing and instrumentation onto the tip of a catheter, as I mentioned, in the tip of a guidewire, including the ability to digitize the sensor information, to include digital signal processing to minimize the amount of data that needs to be transmitted, and even to be able to transmit that wirelessly instead of having to have multiple wires connected down via the catheter to the tip, to the chip on the tip. So all of this technology is moving quite fast and quite powerful in terms of enabling. This is an example of where we were challenged to do peripheral nerve block by anesthetists. Where you have to deliver about 1 mil of anesthetic close within about 1 millimeter of the nerve to enable a day case procedure for peripheral nerve block. How can you tissue differentiation is a big topic for multiple reasons, ranging from cancer resections to, in this case, avoiding damage to nerves. So if you penetrate the nerve with the needle, you can cause temporary damage. If you inject into the nerve, you can cause permanent damage. So this is an electrochemical sensor at the tip of the needle, which allows the nerve to be differentiated from the surrounding tissues. And we can take that into different scenarios, ranging from, this is a smart patch, but it just shows how we can, at the tip of a micro needle on a smart patch, we can put a glucose sensor that can measure interstitial glucose concentrations. Likewise, that sensor could be put on the tip of the guide wire, on a catheter, or any other use case scenario for minimally invasive surgery. And bearing in mind, as we move even from open surgery several years ago, minimally invasive surgery is the standard today, and now we're beginning to move into robotic surgery being the standard. But one of the challenges there is that some of the information is being lost because of the lack of haptic feedback. So a surgeon typically teases things out and knows from haptic feedback how which tissue he's working with, he or she is working with, but some of that information is being lost. So we need these sensors to simulate, to provide that information back. So we can use, photonics was mentioned earlier. We can take the instruments that typically would have been in the lab 10 years ago, or even less, and move those into integrated systems that can be monolithically integrated using photonic integrated circuits or silicon photonics into almost dust-size devices now, which again are compatible with going on to surgical tools, onto implantable devices, minimally invasive devices, and so on. Most of you are probably already aware that the recent chemistry Nobel Prize was awarded for the development of molecular machines. And again, there are many different MEMS and microelectromechanical systems and nano-electromechanical systems that can be put onto the tip of these minimally invasive surgical tools that can measure and manipulate and so on. So we've extremely powerful tools at our disposal these days. So in summary, we're looking at convergence in medtech, pharma, and ICT, as mentioned by Patrick earlier. We have these integrated multi-key enabling technology devices. You've all heard of the 4Ps, the personalized, participatory, preventative, and precision medicine. But most importantly, the closed loop feedback to enable both the delivery of your nanomedicines together with monitoring and diagnostics using nanodiagnostics, where we can adjust the dosage to achieve the desired effect based on real-time monitoring of the patient. And this is critical for the personalized medicine, whether it be a nanotherapeutic, nanoparticle-based therapy, or an electroceutical delivering a pulse via a pulse generator. Getting this closed loop feedback in real time is critical. This data is also critical to the healthcare industry to enable the move from product-based business models to service-based business models, where the reimbursement will be based on confirmation that the therapy has been effective. And so we need to be able to collect this data to show that the thing has been effective. So this brings us full way around to Esther, in fact, which is this multi-CAT approach underpinned by reimbursement models, standardization, smart specialized ecosystems, regulation, involving the various stakeholders, including the medtech, pharma, and biotech industries, the clinicians, hospitals, and patients, and public and private funding for R&D. Thank you very much for your attention. Maybe one question to make sure that we finish roughly on time. Sorry. Yep. Okay, in that case, maybe we move to the next speaker.